Good afternoon. This presentation will review the basics of EKG interpretation and also the most common rhythms that are present in cardiac arrhythmias. What we're trying to do with this PowerPoint is to master EKG interpretation, which I know that takes time and effort. However, I hope this PowerPoint presentation will help you because it's designed to concise and focus on only what you need to know. The parts of the EKG, we have the standard EKG that has 12 leads. 6 of those leads are considered limb leads, since they are from leads placed on the arms and the legs of the individual. The other 6 leads are considered precordial leads, since they're placed on the person's precordium or torso. The 6 limb leads are called lead 1, 2, 3, AVL, AVR, and AVF. The letter stands for augmented, as these leads are calculated as a combination of leads 1, 2, and 3. The precordial leads are called V's, and those V leads are from V1 through V6. I would identify a normal EKG and point out the leads that we just discussed. A normal EKG contains waves, interval, segments, and one complex defined below, which is the QRS complex. Waves, a positive or negative reflection from baseline, indicates a specific electrical event. The waves on an EKG include P wave, Q wave, R wave, S wave, and T wave, and also U wave. Intervals are the time between 2 specific EKG events. The intervals are most commonly measured on an EKG include the PR interval, QRS interval, QT, and RR interval. What are the segments? The length between 2 specific points of the EKG, which are supposed to be at the baseline amplitude, not negative or positive. The segments of an EKG include PR, ST, and TP segments. Complexes are the combination of multiple waves grouped together. The only main complex of the EKG is the QRS complex. There is also points that we will discuss today. There is only one point of the EKG termed J point, which is where the QRS complex ends and the ST segment begins. So we have the P wave, the PQ segment, Q wave, R wave, S wave, which together form the QRS complex. We have the QT interval, the ST segment, and the T wave. And from one segment to the next, you would see the TP segment. Now, when looking at a 12-lead EKG, there are few areas that must be known. First of all, the standard 12-lead EKGs is an EKG of 10-second strip. This EKG is basically a full strip. I actually tried to gather the full rhythm strip. Each EKG is divided by large boxes and small boxes to help measure times and distance. Each large box, which this is the large box, all the thick lines will delineate a big box of 5 tiny little boxes inside. So each large box is 0.20 seconds. There are 5 small boxes in each large box. Thus, each small boxes are 0.04 seconds. Let me illustrate to you. This is lead 1, 2, and 3. This is an extended lead 2, AVR, AVL, AVF, and V1 through V6. The next approach is we need to know the rate, the rhythm, and also examine if there is any particular possibility of cardiac arrhythmia. So let's talk about rhythm. There are 2 different rates that can be determined on the EKG. The atrial rate is indicated by the frequency of P waves, and the ventricular rate, which is indicated by the frequency of the QRX complex. Normally, the atrial rate should be the same as the ventricular rate in the absence of the disease. However, certain conditions such as 3rd-degree AV nodal block or ventricular tachycardia can alter this normal relationship, causing an AV dissociation. In this setting, the atrial rate P waves or ventricular rate QRS complexes are at different heart rates. One quick and easy way to measure the ventricular rate is to examine the RR interval. That's the distance between 2 consecutive R waves. R interval. And using a standard scale to find the rate. If 2 consecutive R waves are separated by only 1 large box, then the rate is 300 beats per minute. In other words, you will try to find an R wave that is at the same level of the thick line. And then you start counting. 300, this is 300. The next thick line will be 150. The next would be 100. The next will be 75. After that would be 60. And you could subtract or add. In other words, if this is 60 and you know that the next number will be 50, you could either add by, if you know that there are 5 tiny little boxes inside, okay, and if a big box measures 0.20 and each tiny little box is 0.04, you will be adding by 4 because 5 times 4 is 20. So if this thick line is 50 and you know more or less that there are 2 tiny little boxes between the 50 and the R, then you do 50, 54, 58, and that's your approximate heart rate. Otherwise, you will subtract from 60 to 50 up till you get up to R, and that would be 60 minus 4, 66, minus 4, 62, minus 4, 58. So it would give you an exact heart rate. Another quick way to calculate the heart rate is based on the fact that the entire EKG is 10 seconds. So by counting the number of QRX complexes and multiplying by 6, the number per minute can be calculated, since 10 seconds times 6 is 60 seconds or 1 minute. This is a better method when the QRS complexes are irregular, such as in atrial fibrillation, which makes the first method less accurate since the RR interval may vary from beat to beat in this setting. Now, the next step would be to determine the rhythm. The rhythm is either a sinus rhythm or non-sinus rhythm. Sinus rhythm refers to the origination of the electrical activity coming from the sinus node or SA node. This results in an upright P wave in lead 2. If there is a P wave before every QRX complex, you have a sinus morphology. A sinus morphology is an upright P wave in lead 2 and a biphasic up or down in V1. So we'll go through all the different types of arrhythmias now. But before we do that, what type of rhythm do you think we're in the presence of? This is basically a sinus bradycardia. So let's talk about the different type of rhythm here. Sinus bradycardia occurs when an EKG under normal sinus rhythm, when there is normal upright P wave in lead 2, preceding every QRX complexes, and there is a standard or the same RR interval, has a ventricular rate of less than 60 per minute. If we calculate the strip in the back, you're going to see that the rhythm is approximately 50 beats per minute. Is regular. You have a P before every QRS and vice versa, and the RR interval is the same. So that is sinus bradycardia. What are the causes of sinus bradycardia? You have to think first, is there any type of medication that is blocking my AV node, such as beta blockers, calcium channel blockers, digoxin? Is there any type of vagal tone being enhanced? Is the patient having pain? Is it pushing? Is it an athlete? I'm in the presence of sick sinus syndrome. Is there hypothyroidism, hypothermia, obstructive sleep apnea, hypoglycemia? Frequently, sinus bradycardia is asymptomatic because heart rates between the 40s and the 50s are very well tolerated. When symptoms arise, they could manifest as fatigue, dizziness, dyspnea on exertion. When there's severe sinus bradycardia, it's a form called sick sinus syndrome, and a pacemaker will relieve any type of these symptoms. Sick sinus syndrome occurs from a sinoatrial node dysfunction and may manifest in multiple different ways. Patients could have pauses after converting to sinus rhythm, sinoatrial node exit blocks, or any incompetency due to chronotropic activity. The clinical signs and symptoms is exactly the same as severe bradycardia: weakness, dyspnea on exertion, fatigue, etc. Patients could also present with a syncope episode or sudden death. This is the leading indication for permanent pacemaker implantation. Withholding drugs that suppress the sinoatrial nodule could improve the symptoms, and those again are beta blockers, calcium channel blockers. Amiodarone is also present as a cause, digoxin, any type of antiarrhythmic medication, and mainly the old one, such as clonidine, lithium, cimetidine, reserpine, etc. Again, few patients have symptoms. The pathophysiology is depending upon the underlying cause, as we mentioned. Sometimes it's basically an incidental finding, particularly in young adults, athletes, or patients that have sleep apnea, or when you're sleeping is being noticed by nurses. Other causes of sinus bradycardia could be an increased vagal tone, such as we discussed already. Pathological causes could be inferior wall myocardial infarction, electrolyte disorders. This is very important for you to assess. Infections, we already discussed sleep apnea, hypoglycemia, hypothyroidism, and even increased intracranial pressure with the Cushing triad. Again, patients could come in with lightheadedness, dizziness, chest pain, shortness of breath, and even with syncope episode as the only manifestation. Pertinent elements of the history that you have to review is any myocardial infarction in the past, any valvular failure, any type of cardiological history, any type of sick sinus syndrome with a pacemaker in the past, medications, toxic exposures, prior illness such as hypothyroidism. Physical examination, patients could come with decreased level of consciousness or syncope, cyanosis, peripheral edema, pulmonary vascular congestion, because remember, the slower the rate, the less cardiac output, the less preload. And initially, you might think, well, basically the patient will be dry, but the heart has to compensate to overcome this decreased cardiac output and will start pumping faster, eventually having sinus arrhythmia and valvulopathies, and therefore pulmonary vascular congestion. Due to decreased cardiac output and ischemia, patients could come with poor perfusion and dyspnea, and manifested as well with syncope. One of the causes, as we already explained, is sick sinus syndrome. You have to rule out if the patient is in digoxin or digoxin toxicity, beta blockers, calcium channel blockers, any type of anti-arrhythmia medication, amiodarone, lithium, fentanyl, reserpine, clonidine, etc. Is this patient septic or were exposed to extreme temperatures? See, having hypoglycemia or hypothyroidism. So basically you have to run the laboratory data for all these type of diseases and go through the list of medications as well to rule that out. So because of that, you have to do electrolytes, glucose, calcium, magnesium, which is part of your comprehensive metabolic panel. You have to do a thyroid function test, a toxicology screen, imaging such as echocardiogram. You could also do chest x-ray for signs of hypoxia and ABG as well. And of course, if this was just visualized in the monitor, you have to confirm it with a 12-lead EKG. Treatment, many patients are asymptomatic, so no treatment is required. If the patient is symptomatic and you have been able to determine the specific etiology, try to eliminate that. For example, if the patient has hypokalemia, replace the potassium. If the patient has any type of calcium channel blocker and beta blockers, if it's not contraindicated to remove them, either decrease the dose or change or remove them. If the patient is hypothyroidism, then you have to do a further workup and provide with levothyroid. Permanent pacemaker if the patient has continuous symptoms or if the cause has not been able to identify. Remember, we already discussed sick sinus syndrome. This is the most common cause for pacemaker implantation. Signs and symptoms are exactly the same of a severe bradycardia. So patients could come with altered mental status, confusion, syncope, due to cerebral hypoperfusion, even in sinus arrest. They could have alternating bradycardia and tachycardia. This is a dysfunction in the ability of the sinus node to generate or transmit an action potential to the atrium, and is pathological. It's very common in the elderly population, though, and is concomitant with other cardiovascular diseases. That's the reason why you have to go through the past medical history and try to discern the possibility of sick sinus syndrome. But many cases are completely idiopathic. The cause has not been able to identify. Clinical presentation, the same. It could be symptomatic as severe bradycardia, and again requires permanent pacemaker. Now we're going to discuss the AV blocks, and there's different types of AV blocks. You have first degree, second degree, type 1, which is winky back, second degree AV block type 2, 2 to 1, and third degree. So let's talk about the different types. A first degree AV node block occurs when conduction through the AV node is slow, thus delaying the time it takes from an action potential to travel from the SA node through the AV node. Recall that the P wave indicates atrial depolarization. So the atrial depolarization eventually spreads to the AV node, where there is a slight delay before the electrical impulses is conducted to the ventricle. If the AV nodule conduction is decreased, it will take longer for the impulse to reach the ventricle. So there will be a greater distance between P waves and QRS complexes, indicating that there is a delay on ventricular depolarization as well. So the main description for first degree AV block is PR interval will be prolonged but constant. So the PR interval is normally 0.12 to 0.20. So this is P right here, and this is the R. So between the P and the R, normally is 0.20 or one big square. So it cannot pass the size of a big square. If you notice where the P starts and the R starts is almost 1.5 boxes. So here we're in the presence of a prolonged PR interval, which is longer than 0.20 seconds or greater than 5 small little boxes, or which is the same, greater than 1 big box. Now we have others, which are the second degree AV block, winky back, and type 2. In the second degree AV block, nodal block, winky back, or Mobitz type 1, varying failure of conduction through the AV node occurs, such as that some P waves may not be followed by a QRX complex. Unlike first degree, AV block nodule, like a 1-to-1 ratio P wave to QRS ratio, is not maintained. Second degree type 1 AV block is specifically characterized by increasing delay of AV nodule conduction until a P wave fails to conduct through the AV node. So in other words, if the first degree was prolonged PR interval but constant, here is progressively increasing PR interval prolongation with each beat until a P wave is not conducted. So it would be an irregular RR interval. In other words, if you start counting right here, and for example, the PR interval here will give you 0.24, the next will give you 0.26 or 28, and the next would give you 0.30, and then you have a P that is not conducting an R or QRS interval, and then starts again. 0.26, then longer and longer and longer until the P would not conduct anymore. Then you have the second degree AB block type 2, which the AB node becomes completely refractory to conduction on an intermittent basis. For example, 3 consecutive P waves may not follow by a QRX complex, giving an EKG a normal appearance, but there is a 4th P wave that may suddenly not be followed by a QRS, since it does not conduct through the AV node to the ventricles. The PR interval may be normal or prolonged. However, it is constant in length, unlike second degree AB block. So what will be the difference between the first degree AB block and the second degree AB block type 2? That the PR could be prolonged but constant. In the first degree AB block, there is no drop of QRS interval, and in the second degree AB block type 2, there is a drop of QRS interval. That's the main difference. Now then it comes the third degree AB block, where there is a complete dearrangement. There is no communication between P's or QRS's. Occurs when no action potential conducted through the AV node is present. This results in the P waves being completely unrelated to the QRS complexes. So the P waves occur at one rate and the QRX complex at another rate. And this is basically what we are seeing right here. It's not truly a part of bradyarrhythmia, and there are varying degrees, as we already discussed. These are the definitions of first degree, second degree, and third degree. So again, for first degree, there is prolonged PR interval but constant. Okay, and here is going to be talking about the same characteristics that I already discussed, and the treatment will be basically trying to see if you're able to diagnose the underlying conditions such as drug overdose, acute myocardial infarction, etc. If the patient is asymptomatic, a first degree AB block needs no treatment. The second degree, remember, you have the MOBITS 1 and MOBITS 2. Okay, here is progressively prolongation of the PR interval. This is the one that goes 24, 26, 28, 30 and drops. And then again 24, 26, 28 and drops. Second degree AB block, remember, is the one that is PR interval is prolonged and constant, but you have a drop of QRSs. Okay, this is basically the pathophysiology. That is basically a delay of infranoduly. Now, the AV block type 2 has a higher risk of progressing to a complete heart block. So this patient has to be monitored in ICU and expecting that they will obtain a pacemaker as well. They have a higher risk for acute myocardial infarction, so the mortality will be higher. Okay, so in MOBITS 1 or AV block type 2, sorry, type 1, most patients are asymptomatic. If you develop symptoms, it will be the same symptoms as sinus bradycardia due to hypoperfusion. Lightheadedness, dizziness, syncope, in MOBITS 2 is exactly the same thing. Now, this one has the higher risk of myocardial infarction due to increased ischemia. Bradycardia is present, and the symptoms are due to hypoperfusion, so hypotension and syncope could occur. Try to determine if it was the vagal tone, if this is an athlete or children that also go through that. If there is any congenital heart disease, if the patient is taking the same sinus bradycardia beta blockers, calcium channel blockers, amiodarone, digoxin, etc. And remember that MOBITS 2, you need to run troponins. And if it was visualized on a monitor, you have to do a 12-lead CKG. They have a high risk for myocardial infarction and death, and convert it into a third degree. So the same as sinus bradycardia, you have to check the electrolytes. You have to think about the digoxin toxicity and check the levels. Because of MOBITS 2, you have to check cardiac enzymes. You have to basically try to rule out causes of myocarditis, such as LAMP titers, HIV patients. You have to do serrate, PCR. Imaging is not required, such as an echocardiogram or any cardiac cath. But if you suspect any type of myocardial infarction, you have to run those studies. Now, complete heart block or third degree is a disorder of cardiac conduction as well. There's complete dissociation, as we already explained, between the atrials and the ventricles. Patients could have an accelerated junctional rhythm, but not a complete heart block. So you have to do an 12 leads electrocardiogram. You have to do an echocardiogram. You have to coordinate for pacemaker on these patients. Symptoms are exactly the same. Okay, from first degree AV block that the patients are asymptomatic to signs and symptoms of hypoperfusion, which are fatigue, dizziness, even chest pain, shortness of breath on exertion, and syncope episode. Remember that because of acute myocardial infarction is one of the causes of and consequence of second degree and complete heart block. Patients need to be evaluated upon that. Troponins and even echocardiogram and cardiac cath if it's indicated. Try to see if the cause is beta blockers, calcium channel blockers, and or digoxin. How would they present? Well, if it's a first degree, no symptoms or minimal symptoms. If it's second degree or third degree, patients could come in with tachypnea, trying to improve oxygenation. They could have congestive heart failure and inspiratory rails. If it's right-sided heart failure, jugular vein distension. Patients could also have signs of hyperperfusion, such as altered mental status, hypotension due to decreased cardiac output. If the patient at the same time has concomitant myocardial infarction, they could present with anxiety, tachypnea, tachycardia, diaphoresis, cool and clammy skin if they're going into cardiogenic shock. This could be a congenital or acquired cause. Congenital forms could be due to tetralogy of Fallop, or because the patient has obtained maternal antibodies due to any type of autoimmune disease, such as rheumatoid arthritis, lupus, or autoimmune disorders. So sometimes cardiologists run the antibodies, which are SSA and RSO, for stroke and lupus and rheumatoid arthritis. Try to also see if the patient is in any class of antiarrhythmic. This, I basically listed the class of antiarrhythmics in case you don't remember from pharmacology. You have class 1, which is quinidine, prokinamide, the most two commons. 1C is flecainide and echinide. Class 2 is beta blockers. Class 3 is amiodarone and sotalol. Class 4 is calcium channel blocker and digoxin, which is not in the classification of class 1 through 4, but it's an antiarrhythmic medication besides being an ionotrope. You also have to, again, remember the cardiomyopathies due to myocarditis, so look for any type of autoimmune disorder or bacterial infection, such as Lyme disease, any type of metabolic disturbances, such as electrolyte imbalances, and remember, think about ischemia and MI into and complete heart block. All the symptomatic patients from 2nd degree to complete heart block, which is 3rd degree, you have to run the ACLS protocol, and meanwhile put a transcutaneous pacer and a permanent pacemaker has to be coordinated. Now, the tachyarrhythmias, the most common is sinus tachycardia. So let's review that a little bit before we go into flutters and AFib. Sinus tachycardia is indicated on EKG with a normal upright P wave, so it has the same characteristics of a normal sinus rhythm, with a normal upright in lead 2, preceding every QRS, and is constant. There is no irregularity. Now the atrial rate is greater than 100. What can cause this? Exercise, anemia, shock, dehydration, fever, hypoxia, any type of pulmonary disease, hyperthyroidism, pheochromocytoma, which is basically elevation of the catecholamines by the adrenal medulla, being dysfunctional, medications like stimulants, decompensated heart failure can give you that, and even a pulmonary emboli. So don't forget pulmonary emboli is rarely a primary cardiac arrhythmia and is most always caused by one of the above conditions mentioned, such as exercise, anemia, etc. The syndrome of sinus tachycardia has been described and is a form of autonomic dysfunction. Paroxysmal tachycardia is when the heart rate is from 150 to 250. Flutter, there's an ectopic rate of 250 to 350, and atrial fibrillation can be faster than that. So what type of rhythm do you have here? If you basically measure the heart rate, for example, try to get this one, which is very aligned with a thick line. So if we do 300, 150, 100, and you discount, if it's 50, okay, 300, 150, 100. Between 100 and 150, we have 50. 50 divided by 5 is 10, so we have to start discounting by 10 instead of 4. So 100, 110, 120. So this patient has sinus tachycardia. Now, for sinus tachycardia alone, patients are not going to go through the ACLS algorithm that we will discuss in class when we meet again. If the patient has an SVT, so sinus tachycardia again is heart rate 100 but less than 150. If the patient has 150 or more, is supraventricular tachycardia. And in supraventricular tachycardia, you have to determine first, if the patient is hemodynamically stable, let's try Valsalva maneuver. If Valsalva maneuver does not compensate and doesn't go back to normal or normal sinus rhythm, or at least a minimal rate chronotopic control of sinus tachycardia. And if the symptoms remain unchanged, the patient has signs and symptoms of hypoperfusion, you could give adenosine. If after 1 to 2 minutes the patient remains the same symptomatic, you could give a second dose. The first dose is 6 milligrams, the second dose is 12 milligrams. If the patient is hemodynamically unstable, you could also consider adenosine, but the best is to do synchronized cardioversion. Now you have to make sure though that the patient goes through the best way in practice is to do an echocardiogram to see if the patient has no clots. So because if you do cardioversion, sometimes you could dislodge the clot and patients could have an emboli. And today, even though we already have discussed the diagnostic evaluations in class, let's talk a little bit about echocardiogram. Echocardiogram is basically to evaluate the presence of structural heart disease. You could combine it, you could do a transthoracic echocardiogram or transesophageal echocardiogram, and you could combine it also with Doppler. Okay. I'm not going to go into detail because that was part of the prior class. There's also an electrophysiology study that the patient could have. It's basically to induce and map any type of re-entrant circuit. And if it's present, you could do ablation therapy or MACE procedure. Other tests that could be done, you could put a Holter on the patient 24 hours or 1 week or 2 weeks to be able to determine the type of arrhythmia that the patient has. Basically to determine what rate the QRS complex is. They could determine if the P's are not usually seen because they're buried inside the QRS, if there is any abnormalities with the PR interval, that there are a few beats that are preceded terminating of the tachycardia, or if there's an abrupt termination with a retrograde P waves. Medical care, again, if it's sinus tachycardia and the patient is asymptomatic, there's nothing to do. Try to determine the underlying cause. If the patient is symptomatic, then you go through the ACLS algorithm that we already discussed. How would you prevent this? If a patient is symptomatic, try to go through the meds. Determine if the patient is taking any beta blocker, calcium channel blockers. For bradyarrhythmias, because this is basically the cause. This is the cause of the bradyarrhythmia, but this is the treatment for the cardiac sinus tachycardia and SVT. So all the tachyarrhythmias are best treated by beta blockers, calcium channel blockers, and digitalis. Why? Because tachyarrhythmias pathophysiology is an increase of sympathetic response, releasing catecholamines, stimulating alpha and beta 1 receptors. So if you block the beta receptors or the entrance of calcium inside this skeletal muscle, you would reduce the frequency of the atrial or the ventricular rate. In addition to that, we already mentioned that patients could go through ablation therapy. And these are the patients that either do not want therapy or cannot tolerate therapy. What type of rhythm is this? This is one of the types of tachyarrhythmia, which is atrial flutter. Atrial flutter occurs when there is a reentrant circuit It is present, causing a repeated loop going back and forth of electrical activity to depolarize the atrium, sometimes at rate as fast as 250 to 350 beats per minute. Now it does produce a sawtooth pattern of the P waves, and that is one of the main characteristics of atrial flutter. You can see here this sawtooth pattern. Now it tends to be regular between RR interval. Very common is the most significant of the atrial tachycardias and tachyarrhythmias. Is very uniform. As I said, it's regular, but it does impede cardiac output. So the patients could have the same symptoms of hypoperfusion, including syncope, and even though it's regular, the atrial rate is not as regular, so it could produce thrombi formation and embolization. So these patients, even though they're not as anticoagulated as atrial fibrillation, they have high risk for thromboemboli event as well. You could have a depolarization of the atrium in the rate of 2-to-1, 3-to-1, 4-to-1, etc. And again, the pathophysiology is a multiple reentrance. You have type 1 and you have type 2. This is the most typical, okay? And basically it's a reentrance circuit at the level of the tricuspid annule. And type 2 is very poorly characterized, but there is a reentrance that is faster than type 1 at the same level. It's associated with patients with heart failure and any other pathologies of the heart. Chronic obstructive pulmonary disease, hyperthyroidism, pericarditis, pulmonary emboli could manifest initially as atrial flutter or atrial fibrillation or any type of tachyarrhythmias. Morbidity and mortality depends on how much tissue perfusion is compromised. And as you could see, the older you get, the more frequency of having this disease. These are the symptoms, and if you see, I don't have to be repetitive because there are signs and symptoms of hypoperfusion. Physical findings, again, patients could come in with hypotension, syncope, blood pressure could be normal or not. They could have peripheral or central embolization due to high risk for thrombi. They could come in with signs and symptoms of CHF, either right or left. Causes, patients that have this, they have a long-standing hypertension, prior valvulopathies, CADs, pericarditis. It could be an initial presentation of PE, patients with hyperthyroidism and diabetes. Remember that one of the main clinical signs and symptoms is CHF, either right-sided heart failure or left. Okay. Additional causes, the digoxin toxicity. Even though it's more frequent as bradycardia, it could be present as tachyarrhythmia as well. Revascularization after angioplasty or CABG. Patients could have atrial flutter. What do you have to do? Well, basically chest x-ray to rule out pulmonary edema from left-sided heart failure. You do the same thyroid test for hyperthyroidism, zero electrolytes and digoxin level to rule out toxicity. You have to obtain a CVC because they could be a sign of severe and profound anemia as well. Blood gases to determine if there is hypoxia. And also remember that these medications are potent vasoconstriction, that it would impede cardiac output and as a compensatory mechanism releasing more catecholamines and produce tachyarrhythmias such as cocaine, ephedra, methamphetamine, all those over-the-counter cold flu cold remedies. EKG should be done, transthoracic echocardiogram, basically to see the right side and the left side of the heart, to see the valves, to see if any type of hypertrophy. You could do also a stress test to evaluate that if the exercise would induce the atrial flutter. You could put a halter. If the patient is hemodynamically unstable, you could do a cardioversion. And again, there's a high risk for thromboembolic event, so do an echo first to make sure that there is no thrombi before you do cardioversion. Treatment, the same as the other tachyarrhythmias that I went through the algorithm. So in addition to that, you could slow the rate with either calcium channel blockers, cardizem or dialtazem, or verapamil, or beta blockers. In addition, if the patient cannot be cardioverted, you could start amiodarone. Basically, your goal is to control the rate, either by beta blockers, try to rule out the presence of thyrotoxicosis, such as in hyperthyroidism. You could do ablation therapy, or you could do, again, cardioversion. What type of rhythm is this? Now we're going to discuss atrial fibrillation. And atrial fibrillation is not regular. Here there is an irregular rhythm. There's no P waves. So basically this occurs when an action potential fires very rapidly within the pulmonary veins or atrium. And it's also a chaotic rhythm. Most commonly encountered in clinical practice, there is absence of coordinated atrial systole. There is, instead of having one ectopic foci of entrance, here there are multiple reentrant electrical waves that are bypassing the SA node. The P waves are replaced by irregular, chaotic fibrillatory waves with also irregular ventricular response. Okay, you see here that instead of having one, this is the sinus node, and you have multiple foci of entrance. There is an entrant foci here, an entrant foci here, another one here. So there is multiple foci of entrance, and the conduction is completely. This is the normal one that is from the SA node to the AV node to the septum and Purkinje fibers, and here there's multiple foci of entry in atrial fibrillation. Okay, the incidence increases as the age advances, the same as the others. And again, there's a high risk of thrombotic events. So patients that have atrial fibrillation, depending on their SHAT score, that we will discuss later on in acute care. If it's, for example, level 1 or 2, patients could be on aspirin and Plavix. But if the score passes 2, patients should be on anticoagulation therapy unless contraindicated. Again, it could appear as a primary type of arrhythmia without any type of identifiable heart disease, or with an identifiable structural heart disease that you will be able to see on the echocardiogram. It could be paroxysmal that lasts less than 7 days and will terminate spontaneously by replacing electrolytes or IV fluids, or depending if it was a surgery. It could be persistent, that is greater than 7 days, that maybe doesn't last indefinitely because you did cardioversion, or it could be permanent, that no treatment will restore that rhythm to normal sinus rhythm. There's loss of atrial kick, so patients with atrial fibrillation have a decreased cardiac output, and there's inappropriately rapid heart rate in rapid ventricular response that, of course, the perfusion is compromised. Patients could have cardiovascular versus non-cardiovascular causes. In the cardiovascular causes could be long-standing hypertension, CAD, CHF, cardiomyopathy, sick sinus syndrome, non-cardiovascular, all the tachyarrhythmias, possible causes that we have discussed already, hyperthyroidism, hyperkalemia or hypokalemia or hypomagnesemia and hypocalcemia, pheochromocytoma, alcohol, smoking, drugs such as cocaine, any type of sympathomimetic, pulmonary emboli, any type of hypoxic episode, and even hypothermia from sepsis. Basically, this is a clinical study that has been done that proved that outpatient, there's a significance between controlling the patient rhythm outpatient versus inpatient, and does demonstrate that there's no clear benefit with control rate outpatient. Patients that have rapid ventricular response, they should be hospitalized because there's high mortality, and that's an obvious. With respect to thromboembolic events, patients must be on anticoagulation therapy. Warfarin, even though it's the oldest of the medication, and we're using Xarelto now and some others, it does lower the risk of stroke when the patient have a SHAT score of 2 or more. This is to demonstrate that there's no RR interval regular, and there is no clear P waves, so the heart rate in the atrium and the ventricle is accelerated because there's multiple re-entrance. Again, the heart rate is irregular, the RR interval are different. The QRS is narrow, though there's no block. And instead of P waves, you have F waves or fibrillatory waves. Now, ventricular tachycardia, it could be monomorphic or it could be polymorphic. And that one could refer to a wide QRX complex that originates in the ventricle, and the rate is greater than 100 per minute. Now, the patients could be hemodynamically unstable, causing severe hypotension, and it could be life-threatening, leading to ventricular fibrillation, asystole, or even sudden cardiac death. And also as well as polymorphic ventricular tachycardia, which it would give you exactly the same, and we'll refer when we come back to the ACC-H guidelines for treatment. PVCs are fairly common in normal, but also could indicate heart disease. Monomorphic BTAC implies that the patients could have a heart disease, so I would do 12-lead CKG and an echocardiogram, and polymorphous for sure leads to prolonged ventricular repolarization and more chances for asystole and BFib and sudden cardiac death. Look for electrolyte rearrangements again, any type of disease that could lead to hypoxemia, any drug toxicity, and the patients could also go into Torsades de Pointes, which is basically a prolonged repolarization. That is like a twisting of spikes is polymorphic ventricular tachycardia as well, that QRX complex are pointing up and then pointing down, is completely irregular. The patients are hemodynamically unstable most of the time, so therefore it could cause syncope, BFib. This is basically a drastic rotation of the electrical axis with prolonged QT interval, very, very short and rapid RR interval. Causes of this could be from electrolyte imbalance, hypomagnesemia, hypokalemia, malnourishment, patients that have are on antipsychotic drugs or antidepressants such as Prozac, Haldol, drug interactions such as amiodarone, amphetamines, pseudoephedrine, patients with heart failure, patients with supraarachnoid hemorrhages or any type of intracranial diseases, hypothyroidism, hyperthyroidism, hypomagnesemia can give you that. And the treatment for that will be basically magnesium sulfate. And if the patient is hemodynamically unstable, they could go through synchronized cardioversion. And of course, if the patient is in ventricular fibrillation, then defibrillation. So we're going to discuss and practice EKG strips when we come back, and also ACLS protocol. The clinical significance is that, again, leads to hemodynamic collapse and even to cardiac arrest sometimes. Then we have the flutter, that the ventricular rate could be greater than 250 without an isoelectric line. And ventricular fibrillation, which is what we do not want, is basically a fatal arrhythmia. The ventricular rate exceeds 400. There's no forward cardiac output, so basically the patient is dead. It's one of the main causes of sudden cardiac death in patients with myocardial infarction. If patients have gone through this, an implantable cardioverter defibrillator is indicated. Thank you. This is the end of the PowerPoint. And next class, we'll meet for practicing EKG changes and ACLS.